Welcome to the Department of Anesthesiology's annual Medication Safety Curriculum. The UNC Department of Anesthesiology is committed to only providing the highest level of care to our patients. Inasmuch, we have developed a continuing education curriculum about medication safety in the operating room. The objectives of this curriculum are first, to improve the understanding of medication safety by reviewing basic medication safety administration principles, reviewing national and local medication error rates, reviewing the UNC Department of Anesthesiology's clinical practice guidelines on medication safety, and also to improve medication error reporting here at UNC by reviewing reportable errors and when to report. While not entirely inclusive, an easy way to remember basic medication administration principles is to remember the 6 rights: the right person, the right medication, in the right dose, via the right route, at the right time, and with proper documentation. Conventional teaching is that while verifying the correct medication, it's a good habit to check that you're administering the right medication at 3 different time points prior to administration: when removing from the Pyxis, while drawing up the medication, and when disposing of the vial. In this prospective observational study, anesthesia-trained staff observed 277 operations and 3,671 medication administrations, of which 193 or 5.3% involved a medication error or adverse drug event. In other words, 1 in 20 medication administrations was associated with a medication error, and essentially every other operation involved a medication error. Do we do it better at UNC? Maybe or maybe not. Let's review some commonly accepted definitions related to medication errors. In February of 2015, the UNC Department of Anesthesiology implemented adverse event reporting through an Epic-based QI tool. Medication errors were a very small representation of the reported adverse events at UNC. Looking at the data more closely, the most common medication errors that were reported were wrong dose or wrong medication. It's very unlikely that we at UNC simply have a lower medication error rate than the national average, and more likely is that we're underreporting our errors. In this study, medication errors were defined as failure to complete a required action in the medication administration process or the use of an incorrect plan or action to achieve a patient care aim. And an adverse drug event was defined as patient harm or an injury due to a medical intervention related to a drug, regardless of whether an error in the medication process occurs. This is a list of the different types of medication errors the article identified. Each of the medication errors are followed by a relevant example that we have observed here in our UNC practice and the potential associated adverse event. This is a list of clinical practice guidelines related to medication safety at UNC. We will review the highlights of the guidelines in the next slides. All medication vials in the perioperative areas are single-use only, even if labeled multi-dose, and are not intended for use in more than one patient. Examples of when you would be inclined to split propofol vials are in locations with many patients and rapid turnover, such as in Hem-Onc clinic, pediatric bronchoscopy lab, and GI procedures. While this practice does save time, it is unacceptable and would be cited in a Joint Commission audit. There was a patient population recently in California that had an outbreak of hepatitis C related to splitting medication vials, and the provider subsequently lost their license. All medications must be withdrawn from the Pyxis systems under a patient name. The only exception is the Pyxis machines located in GI procedures. All medications should be traceable to a patient. Do not enter a generic name such as AAA to pull out medications. Medications should be drawn up using 1 syringe and 1 vial at a time. The label on the vial should be checked and matched to that on the syringe. Syringes should not be pre-labeled in batches. When the codonic safe label system is unavailable, medication labels must be legible and include medication name, medication concentration, date and time of the medication's expiration, which is 12 hours from the time of preparation, and the name or initials of the individual preparing the medication. This applies to either sterile or non-sterile environments. It is acceptable to draw up a medication and immediately administer it to a patient without labeling. In this example, ondansetron is being drawn up into an unlabeled syringe. This would be an example of inappropriate labeling. Scrub every injection hub with alcohol for 10 to 15 seconds prior to accessing for the administration of IV medications and/or IV fluids. This does not apply to appropriately capped stopcock injection ports. Scrub the top of medication vials after uncapping and prior to drawing up medication. Medication vials are not sterile underneath the caps. Immediately discard any medication or solution found unlabeled. Do not leave medications on top of Pyxis anesthesia machines or off-site anesthesia carts when unattended. Given the workflow demands of the perioperative areas, it is acceptable to leave vasoactive medication infusions unattended on infusion pumps for short periods of time. Propofol, benzodiazepines, opioids, and/or other controlled medications must never be left unattended. The Pyxis machines and off-site anesthesia carts must be locked when left unattended. Do not remove safety caps on pre-filled syringes until immediately prior to medication administration. Pre-filled syringes missing safety caps should be discarded immediately. Medications given via infusion should be labeled both on the bag or syringe and at the end of the infusion line. Upon completion of a day's anesthetic cases, the anesthesia cart, including the Pyxis drawers, should be scanned for tidiness and open medication vials discarded. Cap your medications with sterile caps prior to and between administrations. Please use white caps to cover injection ports if you have lost or contaminated the original blue caps. This leads to less confusion than empty syringes and is more cost-effective. These can be found in the drawers above the Pyxis. It is not acceptable to reuse uncovered blue caps that have been left on the machine. Do not double-label pre-filled syringes. Double labeling can lead to confusion and administration of incorrect medications. If the codonics label is not viewable on this syringe, it could be mistaken as a flush and administered as a full code dose of 1 milligram of epinephrine. A large part of medication safety is the ability to change practices based upon our past errors. The EPIC QI tool should be used to capture these errors throughout a case. Reporting medication errors is very important so that we can know how to adapt our practices to improve patient safety. An example of an improvement that we have been able to make because of the QI reporting is that we have more pre-filled syringes available from pharmacy. In the following slides, we will present the list of error types, examples of errors, and potential associated adverse events. Labeling errors can lead to adverse patient events. For example, a mislabeled concentration of fentanyl could lead to under or overdosing pain medication. Giving the wrong dose of a medication can lead to many different types of adverse events, such as hypotension, hypertension, end organ toxicity, and possible related permanent damage such as stroke, heart attack, or permanent end organ dysfunction. Another reportable error is omitting a medication that was planned. This could be failure to redose antibiotics or forgetting to administer ondansetron when it was planned for a patient at high risk of post-op nausea vomiting. Proper medication documentation in the electronic medical record is incredibly important. Forgetting to document a medication administration can lead to under or overdosing. Another example is preoperative oral NSAID administration and the potential for renal toxicity if intraoperative ketorolac is also administered. Administration of the wrong medication is often related to similarly labeled vials, medications being in the wrong place, or double labeling medications. Identification of these issues through reporting can help us improve our systems in the future. Inappropriate timing of medications can lead to patient harm, such as drug toxicity, such as with incorrect dosing interval or administration over too short of a time period. It is important to be cautious when bolusing medications when infusions are running in the same IV. If an inadvertent bolus is given, it is important to document in the chart and report it as an error. There are many more types of medication safety errors that should be reported. For example, unattended opioid medications put your colleagues at higher risk for diversion of controlled substances and potential abuse. At UNC, we hope to improve our culture of reporting, and we want to encourage everyone to feel safe in admitting mistakes. There is no punishment for reporting perioperative medication errors, and we hope that we can see some improvements in our reporting data after this curriculum. In conclusion, medication safety is a very important part of our careers as anesthesia providers. Errors occur much more often than we think and can lead to potential patient harm or adverse events. Our goal is to provide the safest care for our patients, and this starts with following basic medication safety guidelines and reporting our errors in order to improve our practices. Thank you all for your time and effort. Thank you to the resident QI team who created this curriculum, Stephen Acosta, Brian Specht, Katie Fitzgerald, and Lindsay Gauker. Thank you to our faculty advisor, Dr. McDaniel, and our project coaches, Dr. Conrad and Dr. McNall. These are our references for the national average data and the UNC guidelines for safe administration of medication. Thank you again for your time and attention.